So questions from the committee? Scott.
Thank you, Malcolm. I enjoyed your presentation. Thank you. I'm struggling conceptually, and we talked about and you know, as a group, we need to be very sure about the conceptual basis when we're thinking about this field. But I'm struggling with team training and IPE that you've mentioned. You talked about IPE being in team training and IP and team training. And Brenda mentioned earlier on this morning about task training as well, because we're not quite sure, you know, what is team training sounds very reductive. And how does it differ from interprofessional education, which is what we're trying to sort of look at?
I don't think that it differs. I think that team training is one part of the larger interprofessional education spectrum. I think it helps to distill down the specific competencies that need to be imparted. But interprofessional education is a much larger effort. And in terms of your question about task and team training, for this particular meta-analysis, we only used studies that evaluated team training separately from task training, simply because the task training sometimes confounds the behaviors on the job outcome. So we wanted to make sure that our outcomes were reflective of just the team training, and that includes competencies of leadership, coordination, mutual support, situation monitoring. So anything that dealt with training on clinical skills, how to approach the task more efficiently, anything like that was excluded so that we wouldn't confound our outcomes.
Thank you, Shirley. You and Dr. Salas have done great work. Just a few questions, and I know it's a meta-analysis, and you may not have the answers to this, but it might help us to think about this. Were the teams that were being trained intact teams, or were they being trained around team skills?
Some were intact and some were ad hoc teams.
Okay.
But in the meta-analysis in 2008 that Dr. Salas conducted, he did find that team training was as effective for intact teams as ad hoc teams, so that doesn't make a huge difference in terms of imparting those competencies.
Okay, just to follow up, you mentioned that the longer the training was, the duration, the dose question that we keep asking about, there was better outcomes, but there was no range of the dose. So 1 hour, 4 hours, 8 hours?
The average was 8 hours, but that I interpret that result with caution because some of the training was spaced over time and some was 8 hours straight. So what we know about spaced learning research is that, you know, when you provide time in between the sessions, learning is going to be enhanced and improved, and retention as well. So I think we need to take a deeper dive into that moderator analysis, because we do need to determine whether 8 hours all at once is better than 8 hours spaced over time versus, you know, other lengths of time. So I don't have an answer to that question, but it does warrant a deeper dive if that's something that, you know, is critical to know for the implementation of IPE. Team training.
The measurements were taken at the end of the training, whether it was...
We coded for that as well. Not all measurements, some were taken immediately after training, but for things like transfer to the job, those were taken sometimes weeks, 1 week, sometimes several weeks after the training to see, you know, on the job performance, which is impossible to assess right after team training.
And just, I'm sorry, I just want to ask one follow-up with this is all the same thing. Is the models, were there any train the trainer, because of the cost of team training is huge because you pull teams, you know, away from practice. So is there, was there any of these teams were being a train the trainer model like the Team Steps model is?
There were many of those train the trainer. I don't have specific numbers because we didn't actually code for that information, but just anecdotally from what I've read in literature, many of them are train the trainer.
Thank you.
Yeah.
Janice.
Thanks, Shirley. You and Eduardo are doing great work, especially for my field. Janice Palganis from the Center for Medical Simulation. So my question is around simulation, actually. You spoke of simulation as a learning strategy, and yet you and Tina have brought up and highlighted that there are these missing steps from education to measuring patient outcomes, and I see simulation playing a much larger role in being that platform that can measure some of these steps. And so I'm wondering if any of the studies use simulation as the measurement tool versus the learning strategy.
Many of them did, and simulation was sometimes used as a practice opportunity, and when it was used as that, we coded it as practice. But oftentimes, the outcome was their performance in the simulation. So very often, it is used as an assessment strategy, as you say. And by the way, when simulation was used, the majority was high-fidelity human patient mannequins. So I do think we need to use simulation as an assessment strategy in addition to practice. But like I said before, we need to specifically and explicitly report what that simulation looked like. And were the observers trained? What are they looking for in terms of behaviors? Very little of that is actually reported in the literature. And in order to propel the field of simulation, the field of team training, and to have more robust evaluation, we need to model it on evaluations that are robust and that work, and we need to know explicitly what was done. So, yeah.
The questions from the group? Please.
Yeah, this is Pat Hinton-Walker from Uniformed Services University. Since you had it up there, I thought I would just share a couple of the results we've seen from the research within the DoD,
Oh, great.
which uses team steps, by the way. And two things that were interesting is that, Brenda, in reference to your intact teams, we found that it was not so much intact teams, but in where the care, like in OB or ICU or surgery, we found that those teams benefited more than where you had a very dispersed and different population. So it wasn't necessarily an intact team, but we calculated it in the context of a common goal that they could get their hands around and a common body of knowledge, not necessarily interpersonal. And then the second one was a study that one of the doctoral students did looking at a path analysis related to patient safety culture. And what we found in the acute care arena is that team within was, after team steps, was the most dominant predictor of seeing a difference in the overall score of patient safety culture. Not team across. Team across, interestingly, failed, but team within was a very high predictor of seeing a difference in patient safety culture. And then when we scaled it, and I think you didn't address it in yours, but when we looked by provider group at where the satisfaction and dissatisfaction was, in the acute care arena, we saw differences between nursing and medicine in terms of view of patient safety culture as it related to team. And in the ambulatory care, the difference was nurses and physicians were together, and the difference was with pharmacists. And so it was just a very different perspective once you start also drilling down. But I think the team within experience over looking at the overall patient safety culture scale was pretty significant. Just wanted to share that.
Can I respond to that?
Of course you can.
Okay, thank you. Thank you, Pat. And I guess a question I have for both of you is, HRSA is investing a lot of money right now in the nursing workforce side, the Bureau of emerging leaders in teams to develop them. So, and either of you can comment about, was there any purposeful training for a leader? I don't mean the situational leader in the team steps where, based on the clinical decision that needs to be made, somebody can step up and do that, but really teaching team strategies to the leader so when they go back into their practice, if this is in simulation, they can lead the team in team-based care.
We didn't have that in an overt way, but partly just because of the structure of the military, it was there indirectly, I guess is a good way to put it.
Thank you.
Sonesh, you have any comments on that?
We did see some training that was focused only on leadership, and then some also that looked at shared leadership, training shared leadership, so knowing when to step in as a leader when maybe your leader is gone or not performing properly. So yeah, we did see some of that.
I think it would be more that we would have stressed what we would call informal leadership, so that wouldn't necessarily be a guided leader, but situational, informal leadership of willingness to step forward and lead.
Maria.
Thanks for your presentation, Shirley. Maria Tassoni from the University of Toronto and the Canadian Collaborative. This question might turn out to be a micro question, or it could be a fundamental question, so we'll see what it sounds like when it comes out. And it stems from three places. Scott's comment about sort of the distinctions in relationship between team training and interprofessional education. Tina's presentation earlier this morning about in the quest to look for some of the evidence, that often the studies that were perhaps easiest to find were those that really described the IPE intervention, and that often was something very, very structured like team training. And the third place it comes from is pure curiosity on my part, because I'm not an expert in team training. So my question is, if you can apply team training programs uniprofessionally, what is it about them that is interprofessional? And I think that's both basic and fundamental to our question of how the panel grapples with that.
Okay, so team training that was uniprofessional, I don't think we can call that interprofessional education, really. And the goal of originally when we conducted this study wasn't about interprofessional education, it was just about team training in particular. But I do think that by training even uniprofessional teams, it imparts upon them individual skills that they can contribute back when they do have an interprofessional team experience. And I think that Tina had mentioned earlier that there is team training that is delivered individually. And sometimes that, I'm not saying it's ideal, but sometimes that is enough to know these are the communication protocols I need to engage in when I engage in teamwork. This is when and when not to step in as a leader, as an emergent leader or an informal leader. So kind of having that as a basis to then step into an interprofessional team might be enough. I don't have the evidence to back it up, but just anecdotally and from what I've read. So I'm not sure if that answers all three of your questions, but that's kind of how I describe that uniprofessional team training.
I guess, just a comment, I guess the real question is, we know about the effectiveness of these various forms of team training. What we don't know is the cost, and hence the relative value. And if it were less expensive of time and resources to focus on one particular modality, and yet the effectiveness was a small difference or no difference, then one would go for the cheaper intervention. So I wondered if you could just comment. I know you didn't look at cost and those kind of things.
Yeah,
but
we
just
didn't
from
look
your
at cost,
experience.
but I think that something that needs to be more researched is a completely different modality, which is virtual team training, because time is something that is a valuable resource. And so something Dr. Salas and I have been talking about is developing team training to go on a mobile platform. And we're not sure exactly what that would look like, but we could, in our lab, could design an architecture of the team skills that need to be embedded in this virtual team training tool. And depending on, I mean, there would be a lot of upfront costs in developing that, but if that were widely adopted, that would be a very minimal financial cost, minimal time-based cost, because you wouldn't have to logistically get everybody in the same room, but you can do a simulation on a mobile team training tool where you have avatars and you can hand somebody a scalpel as mutual support, and that kind of represents implicit coordination. Those are just some ideas we were thinking about in terms of how do you do this where you have a team member, a team that's virtual or can't train in the same room. So that's one way to do it to reduce cost, and if that were to pan out, we could assess ROI.
Tina, I think you were waiting, were you not?
I hesitate only because I should probably quit while I'm ahead, but Jill emboldened me to be a little bit provocative. We did just a study at the University of Virginia where we compared interprofessional mentorship, where we trained the faculty to function as an interprofessional team in mentoring uniprofessional groups of students versus interprofessional groups of students. And we found that the interprofessionally trained mentors of uniprofessional groups of medical students had a huge impact on their ability to create a comprehensive team-based approach to patient management. Now, this is just one study. It's with undergraduates. But I think that, everybody kind of gasps at the thought of getting away of our original definition of interprofessional education. I was almost sad to see that because I know what's going to happen when that data gets out. On the other hand, it's a lot easier to get invited as a team to medical grand rounds or nursing grand rounds and potentially have an impact than it is to have what I'm trying to do right now for a visiting professor is have a combined grand rounds, if you will. I mean, as a simple example. So I think as much as we might wish it was different or hope for a different, I think we have to be open to that as a reasonable approach. So thank you for presenting that
Really
data.
fascinating.
Yeah, I mean, all of this does fly against, sort of either our comfort zone or dogma or something, some combination. You could even imagine online training in which you teach people all of the knowledge they need and give them exercises and inspire changes in attitudes and perhaps allow them to behave better when they are actually in a group of people. It's not, it seems a little heretical, but I think that given costs, I think we have to keep an open mind. That certainly seems better than not doing anything at all.
This question about uniprofessional versus interprofessional, I mean, I think it comes back down to what your learning outcomes are for the team training that you define. So if they're about working in a team, then yes, you may be able to do that uniprofessionally. If it's about working in a team where there's hierarchical relationships, then I think you need to do that interprofessionally. And I saw an example of that in Singapore, where they were trying to have joint ward rounds between the nurses and the doctors. And until they put them together to thrash out the fact that nurses would never, ever ask questions of doctors on a ward round, and they could actually practice that, it just, that just was never going to happen. So I think it comes back into the plain old educational setting your defined learning outcomes and then deciding what the activity is that can meet those best.
Right.
Yeah.
My comment goes to emerging information that might be helpful to the committee on the pre-qualifying side of things. I heard a webinar last week that was very impressive from the work that Western University is doing in preparing across 9 professions interprofessionally to work asynchronously in community contexts where the concentration is on individual learning, but that individual learning goes along these lines. You're going to be practicing in a community where you're not looking at each other face to face, and you have to learn how to build a team from where you are to coordinate care in a community context. And so they are developing assessment tools and ultimately a toolkit, which I believe will be released this coming spring, but the committee might want to pursue this from them now, where they use an assessment approach to how well those students, I believe at the senior level, who will be moving into the community, can do things like mobilize others to work together in the community around patient needs. And they are using some of the strategies that they're teaching students come from earlier training that they have, starting with team steps. So like the 2 challenge rule, which we associate with team steps training and patient safety context, are being used by students in terms of the pushback they get
from professionals they might be conversing with over the phone around patient needs. So I think there are some new models out there that are worth having the committee look at in terms of what's happening on the pre-qualifying side.
Brenda.
Shirley, would you see that team science being perhaps a foundation before we start IPE, that learning how to work effectively as a team member and the roles and responsibilities and the changing leadership might be foundational skills, and then we put people together that have problems with understanding different roles and hierarchy, et cetera?
I believe it should be the foundation. I mean, that's the kind of stuff I research, team science. So the specific, again, you can't build team training unless you know what the general learning objective is and use that to build the knowledge, skills, and attitudes. Only then do you contextualize the team training around those knowledge, skills, and attitudes. So I think that understanding those principles and that science behind teamwork is crucial before we, endeavor upon this pretty lofty goal of interprofessional education. And from this, meeting, we know that it can mean so many different things. And depending on what perspective you take, it can mean a heterogeneous variety of things. So I do think that we need to go back to the basic science, basic principles before, building a larger curriculum around it.
Barbara.
Shirley, so to me, this team training approach is always rather quote, quote, traditional. It's within an organization. Where does it go when you start to talk about patients, families, and communities? What does that look like?
That's a great question. I think the approach we took was traditional simply because that's what's out there. That's the research that's being conducted. I think moving forward, we need to consider something that's really interesting to me is telehealth and interprofessional teamwork required to provide quality care through telehealth and virtual teams. It's not a question I can answer very specifically because there's room for so much work. But that's certainly a question that we need to take into consideration in terms of moving team training forward and moving it to be more virtual and to adapt to the needs of community and patients. So, yeah.
We think of, from a curriculum perspective, generally, could we think of graduated levels of team training? That is, you might start with a baseline, let's call it general, 101, team training 101, and then add at some later point in the curriculum during a different kinds of experience, team training 102, et cetera, et cetera.
Yeah, we have kind of experimented with kind of scaffolding the team training in terms of the practice to be more difficult. And the way that we do that with simulation-based training is just throwing in some more triggers where the team needs to adapt very quickly. And to adapt, you need to have those basic team skills, that knowing when to be an informal leader and an emergent leader. And we did do a telemedicine study with the University of Miami, where we simulated, it was with the DoD, and we simulated a mass casualty disaster. And we looked at their teamwork. And to make it more difficult, we would throw in some triggers. And these triggers were the power generator went out. And they were supposed to be in Iraq or in Afghanistan. So the power generator went out. You have no light. What do you do? Your surgeon was just killed. A terrorist just came in. So all these various triggers made coordinating that much more difficult. And the goal of that specific project was to see if telemedicine would help to kind of reduce that stress and improve teamwork. We didn't find much simply because we made the triggers so difficult and so stressful that they didn't have time to think about how to now initiate telemedicine and interact with that expert clinician. So if we were to replicate that study, I think maybe we should look at telemedicine in non-stressful events to see how that affects teamwork, and then maybe look at very stressful situations. So there are ways to kind of scaffold the assessment of teamwork. In terms of the training itself, if we were using that, again, this goes back to using simulation as part of the training or simulation as the assessment. If we're using it as the training, yeah, certainly we can build events and scenarios that are more difficult in terms of using your teamwork at the appropriate times. In terms of assessment, it's also a great way to.
Other questions or comments? Scott?
Thanks, Malcolm. Just a very quick one. Just reacting to your point about team training curricula. Again, and anyone who knows me, and I keep talking about this, I think we need to move on about thinking of just teams and team training. These are interprofessional. We need to think about interprofessional competencies more broadly, thinking about the different types of interprofessional collaboration that exists. So yeah, teams are one component, but there are networks, groups that work more asynchronously. We need sort of skills and knowledge and attitudes to sort of be able to work with those as well. So it's not just the team and teams that we're talking about. There are, in a lot of my work, I do a lot of ethnographic work, ICUs, intensive care units, general internal medicine units. They call themselves teams, they're not teams. They're different types of configurations. And we need to train people to understand what they are, to see them, to diagnose them, and then to be able to work within them more effectively. Because this rhetoric of teams and teamwork is a bit misleading, and I think it's not going to be helpful if we're trying to measure something and we haven't got the right terminology.
And if I could just add one thing back to adding the patient in, and I think it's just an important element that just like our dialogue changed here when we brought students and patients into our dialogue here, it changes the whole interaction of what happens even within team steps. So it makes a difference on who comes to the table in addition to the interprofessional practitioners.
Thank you all, and thank you in particular,
you.
Dr. Sonesh, for stimulating discussion.
My honor. Thank you.
We have a 10-minute stretch break while we connect the electrons between here and Miami, and then we'll continue.